For pulmonology, obstructive lung disease, asthma. Asthma or reactive airway disease is an abnormal constriction of the airways. Although asthma is very common, its etiology is unknown. It is reversible. Prevalence, incidence, and hospitalization rates are all increasing. It is associated with atopic disorders and obesity. The main difference between asthma and COPD is that asthma is reversible, while COPD is not. Acute exacerbation of asthma has many causes. Allergens, example pollen, dust mites, cockroaches, cat dander, infection and cold air, emotional stress or exercise, catamenial related to menstrual cycle, aspirin and SAIDs, peer blockers, histamine, any nebulized medication, tobacco smoke, GERD. An oral temperature may not be accurately measured and patient breathing fast. Mouth breathing cools the thermometer. Breathing with the acute onset of shortness of breath, cough, and chest tightness makes what is the most likely diagnosis question unlikely. Increased sputum production is common, although fever is not always present. Asthma can present exclusively as cough. Here are the following the most likely to be seen in this patient. Symptoms worse at night, renal polyps and sensitivity to aspirin, eczema or atopic dermatitis on physical examination, increased length of expiratory phase of respiration, increased use of accessory respiratory muscles, example intercostal. Okay, make sure you can identify the sound of breathing. This is a good multimedia question. Diagnostic testing in asthma, especially the best initial test, is based on the severity of presentation. Peak expiratory flow (PEF) or arterial blood gas (ABG), the initial test in acute exacerbation to determine function. Test actually to exclude pneumonia as a cause of exacerbation and in cases that aren't clear to exclude other diseases such as pneumothorax and CHF. Test actually is typically normal in asthma but may show hyperinflation. PFT is pulmonary function test. Most accurate test pyrometry will show a decrease in the ratio of FEV1 to FVC. FEV1 decreases more than FVC. Decreased FEV1 and decreased FVC. Post visceral capacity. Decreased FEV1 greater than 12% and 200 ml with use of albuterol. Decreased FEV1 greater than 20% with use of methacholine or histamine. The choline is an artificial form of acetylcholine used in diagnostic testing. Acetylcholine and histamine provoke bronchoconstriction and increase bronchial secretions. Increase DLCO. Peak flow extremely depend on height. In between exacerbations of acute asthma, PFTs will be normal. Asthma diagnosis, FEV1 increased 12% albuterol, FEV1 decreased 20% methacholine. Complete blood count may show increased eosinophil count. Skin testing to identify specific allergens that provoke bronchoconstriction. Increased IgE level to suggest an allergic etiology associated with allergic bronchopulmonary tuberculosis. IgE level may also help guide treatment. Examine the use of the anti-IgE medication omalizumab. 4.1 Pulmonary function testing. TLC, vital capacity, expiratory reserve volume, inspiratory capacity, expiratory reserve volume, residual volume, functional residual capacity, expiration, resting tidal volume, inspiration, given TLC 100%, vital capacity 80%, residual volume 20%, IC inspiratory capacity 60%, for functional residual capacity 40%, inspiratory reserve volume 50%, tidal volume 10%. Now, expiry reserve volume 20% and residual volume 20%. Pulmonary function testing. A 15-year-old boy presents with occasional shortness of breath every few weeks. Currently, he feels unwell. Uses no medication and denies any other medical problem. Physical examination reveals a pulse of 70 beats per minute, respiratory rate of 12 per minute. Chest examination normal. Which of the following is the most accurate diagnostic test? The greater than 20% decrease FEV1 with use of methacholine. When a patient is asymptomatic, it is unlikely to find increased FEV1 with the use of short-acting bronchodilators such as albuterol. When there are no symptoms, the test may be falsely negative. When a patient is asymptomatic, the most accurate test of radioactive airway disease is a 20% decrease in FEV1 with use of methacholine or histamine. Chest CT, like X-ray, shows nothing or hyperinflation. Arterial blood gases and PEF are useful during acute exacerbation. Flow volume loop is best for fixed obstructions such as tracheal lesions or COPD. Methacholine challenge testing has 1 to 2% risk of inducing status asthmaticus. Treatment of asthma is done in steps. That is, treatment should be added progressively if there is no response. Step 1, start with an inhaled short-acting beta agonist, SABA, example albuterol. Pyrbuterol and levalbuterol. Step 2. Add a long-term control agent. Example, a low-dose inhaled corticosteroids. Beclomethasone, budesonide, tunisolide, fluticasone, mometasone, and triamcinolone. Never use LABA first or alone. That is, LABA is first or alone. Okay. Now, chromonil, nadochromil inhibit muscle mediator release and eosinophil recruitment. Theophylline, leukotriene modifier, montelukast, zerfelukast, hepatotoxic, associated with Gortrog syndrome, zerfelukast, Zilutan, best for atopic patients. Now, substitute long-lasting beta agonists, LABA, example salmeterol or formoterol, or increase the dose of the inhaled corticosteroids. Step 4. Increase the dose of inhaled corticosteroids to maximum in addition to the lower LABA long-acting beta agonist and the short-acting beta agonist at tiotropium, an antimuscarinic agent. Step 5. The parent has elevated Ig or eosinophil count as a monoclonal antibody against interleukin or Ig to the SABA, LABA, and ICS. Step 6. If symptoms are still not controlled, add an oral corticosteroid, example prednisone. Side effects of inhaled corticosteroids are dysphonia and or candidiasis. However, high-dose inhaled steroids rarely lead to the side effects seen with prednisone. Influenza and pneumococcal vaccine are given to all asthma patients. Now, use steroids as a last resort because of hard side effects, example osteoporosis, cataract, adrenal suppression, fat distribution, hyperlipidemia, hyperglycemia, acne, hirsutism, particularly in women, thinning of the skin, striae, and easy bruising. To avoid steroid therapy in parents on short-acting beta agonists, long-acting beta agonists, inhaled steroids, leukotriene modifier or theophylline, try monoclonal antibodies, reslizumab, okay, whatever, for anti-interleukin effect at eosinophil levels are elevated, and omalizumab for anti-IgE. Bronchial thermoplasty or heat probe removes constricted muscle from around bronchi is the last resort. If short-acting beta agonists, long-acting beta agonists, and inhaled steroids are not present, use an anticholinergic which will dilate bronchi and decrease secretions. Anticholinergic inhalers have an effect in both COPD and asthma. They are used as a later choice in asthma. Acute asthma exacerbation. Severity of an acute asthma exacerbation is quantified as follows. Decreased peak expiratory flow. Approximation of the port valve capacity with no precise normal value based mostly on height and age, not on weight. Used in acute assessment to compare PF, peak expiratory flow, with usual PF when patient is stable. Arterial blood gas with increased A to A gradient. In extremely severe asthma, breathing stops when there is loss of air movement. Chest X-ray may be done to see if there is an infection leading to the exacerbation. Asthma likewise predisposes patients to pneumothorax. Treatment of acute exacerbation is as follows. Oxygen plus inhaled short-acting beta agonist plus bolus of steroids plus initial treatment. Corticosteroid needs 4 to 6 hours to become effective, so administered right away. Albuterol, ipratropium is used but works more slowly than albuterol. Epinephrine injection rarely used is no more effective than albuterol but has more severe side effects. Magnesium has some modest effect on bronchodilation and reduction intubation for mechanical ventilation if there is no response to oxygen / albuterol / steroid or respiratory acidosis. Increased pressure of carbon dioxide develops. The following are not effective in acute exacerbation. Theophylline, chromonil, and nadochromil, best with eccentric allergies, example hay fever. Leukotriene modifiers, omalizumab or any of the interleukin inhibitors. Long-acting beta agonists, salmeterol, formoterol, olodaterol, and vilanterol. For 7-year-old man with history of asthma comes to the ED with several days of increasing shortness of breath, cough, and sputum production. On physical examination, his expiratory rate is 34 per minute. He had diffuse expiratory breathing and a prolonged expiratory phase. Which of the following will be best indicate the severity of his asthma? A. Expiratory rate. Normal expiratory rate is 10 to 16 per minute. Expiratory rate of 34 per minute indicates severe shortness of breath. Necessary muscle use is hard, research, and is subjective. Pulse oximetry will not show hypoxia until the patient is nearly at the point of imminent respiratory failure. Oxygen saturation can be maintained above 90% by hyperventilation. Pulmonary function test cannot be done when patient is acutely short of breath.